So I will be moderating the session. I'm Robert Stiles. I'm the CEO of CCNK. Still kind of weird to say that. And really excited that we will be having an hour and a half to really talk through and answer some questions. I hope you guys will begin to develop questions and think through things that you'd like to ask our amazing panel of people. So we have a couple housekeeping items. Just please silence your phones. I've tried to silence mine. If it rings, I'm sorry. I do the best I can, but I'm not always great with technology. Please check in on the conference app using code 4117 so you're counted as attending the session. There's also sign-in sheets on each table. Please complete your evaluation of the session in the conference app. I know you're going to say it's amazing and that we should have them every year, and we're going to do our best to do so. So really excited to have our esteemed panel here today. I'm going to go up there and for some reason, I don't have everyone's lengthy discussions of their background. I apologize. Be happy to.
It's okay. They know.
Everybody knows who you are. So, great. I don't know if this is the work I'm turning on. Can you hear me? Yeah, very loudly. So I feel like, first of all, this is like The View or what? Actually, a long time ago when Kathy Weno was the dental director for the state of Kansas, she and I was at KDHE at the time, we would they'd always have us on a morning session, and we used to call it Live with Robert and Kathy Lee, even though that's not her middle name, because we would sit on stools and talk about things. So I'm glad to kind of get back to that. So really pleased, kind of just going down the list so everyone knows, we have Secretary Laura Howard from KDADS and from the Department for Children and Families. We have Secretary Stanek from KDHE. They're in two different chairs than on my list, so I'll have to remember not to ask the wrong questions to the wrong ones. We have Christine Osterland, who is the State Medicaid Director. Really pleased to have her. And then Dr. Dana Brinkman, who is the State Oral Health Director, as well as the head of the Bureau of Oral Health. So we really want to thank them for being here today, and also thank them for believing so much in our work. Many of them have experience with our work, have worked, Dr. Brinkman, for example, has worked in one of our clinics. And so really appreciate that they value and understand how important the work that CCNK does, and how we really serve as that backbone, kind of filling in the gaps for those places where people don't have the access they need throughout the state. So we have a series of questions that we'll kind of ask, but as I said already, please, please, please think of questions that you have. This is a really great opportunity to have a conversation. So the first question we kind of have for each person on the group is really just kind of wanting to hear, we often come to your agencies and your programs and are asking for stuff from our side of things, and really are curious about how can our member clinics, how can Community Care Network better partner with each of your programs and your agencies in order to really improve the health of Kansans overall. So start with Secretary Howard, please.
Thank you, and thanks for having us here today. We're always excited to come. I always tell folks you're one of my favorite groups, and I really do mean that. So when I first came to KDADS and was going to lead behavioral health, I just said this to Robert a few minutes ago, that's always very much about being the behavioral health authority and working with the community mental health centers. And the first day I said to my behavioral health director, I want to find a way to work with the FQs and the RHCs and with the Community Care Network. And I think we've been really successful in doing that. So I think the first thing I would say is I think to continue to collaborate on the work that we're already, doing together through the Secretary Care Collaborative, the large federal grant that we have, and feel like we've had a few periods of time over the last few months where we were kind of like, is this going to continue? And then we got the notice for the next year recently, so we were really happy about that work can continue on the pace that it was continuing, and and it's got really good outcomes. So I think in terms of that work together on integrated care, I'm really excited about that. I'm also interested in exploring, when we did some strategic planning inside KDADS recently, one of the things that we've been talking about outside of the behavioral health arena in our long-term services and supports area and in our aging area is what some health outcomes might look like for those populations. And so I don't have that much to say about it today, but as we begin to put just a bit more emphasis on issues around the intersection of health and aging, the intersection of health and disabilities. I think you're certainly a group we'd like to have at some planning tables around that. So again, as we kind of look forward to maybe what's next. So.
And we really appreciate that KDAD sees the FQHCs and our other member clinics, and also that behavioral health integration is the way to go. One of the things that I've always talked a lot about is, in a rural community or somewhere, and actually Bob Mosher talks about this as well with the Care Collaborative, and they work on behavioral health, that, unfortunately there's still a stigma when it comes to behavioral health. And the more we can get services integrated, whether that's in the CCBHC, doing other types of services and supports, partnering with CCBHCs, so that we can kind of reduce the stigma, but also, not everybody in town knows why you show up at one of our clinics. You could be there for lots of reasons. And we know that that's a really important thing, to make sure that the system is both integrated and coordinated. One of the things I've been saying a lot is, we need every part of the system. We don't have enough to begin with. So we can't be spending our time saying, well, if the CCBHCs, if we just had this, I think it's really important on that partnership. And so I especially appreciate you guys kind of understanding that one of the things to do is, what can we do to motivate and help make it possible and affordable for the different parts of the system to work better together. So I really appreciate the integration funds.
Yeah, thank you, Robert. We're also really excited just that the Sunflower Foundation continues to stay very involved in the issue of integration. And we were pleased to use some funding left over from that grant to help with some technical assistance through that project. So again, I think just continue to advance the work across systems for integration.
And Secretary Stanek, so many different things and ways we interact with KDHE. And really excited to have some of your other staff presenting later about the primary care and rural health and all the work that happens there. But across the board, when you think about the work of KDHE, what are some of the areas that we can be better partners and that we can support the work of KDHE?
I think some of what Secretary Howard said and what you said, the term integration, I think one thing I'm going to focus on funding and our role in trying to figure out, it can't always be about more money. It's got to be about a redesign of care delivery and also getting the patient to the right care setting. And I think we all have a role in that. And sometimes, and you could partner with us, I guess is my point, a little bit more. We could work together. We're going to have to. And looking at what we do every day and saying, is this what we need to continue to do? Are there other alternatives? And what does that free up maybe for you? How can we get more efficient? And again, focusing on the patient and getting them to the right place. I think that partnership, whether I was talking to the Hospital Association, mental health, or anyone else, I would have the same discussion with them, because I think we're going to be forced to that at a level that we haven't been before. And that might not, I don't want to say funding cuts or funding adjustments are a bad thing, but it might be a way to push us to think differently and a little bit more strategically. Thanks.
One of the questions that's come up is, we're so concerned. Well, actually, let's go ahead and go to Christine Osterlind and to Dr. Brinkman, but really interested from all of you. And our next question, to really think about some of the federal impacts and how we can help support the work and making sure Kansans have healthcare. So please go ahead, Christine.
In the Medicaid space, question 1 and 2 definitely go together. I mean, obviously, I think as everybody knows, the Medicaid world is dramatically changing. This new administration has some very strong opinions around the Medicaid program and where we should be focused. Obviously, a lot of focus on fraud, waste, and abuse. A lot of focus on controlling spending. Our world is dramatically changing. And I think where we really need our provider community is, how do we balance that fraud, waste, and abuse and cost cutting, which, to be honest, in Medicaid is not a thing. You never cut cost, you control growth. But how do we balance that with serving the patients? Because that pressure to control cost and the number of audits that we have going on right now, both from the federal level and from our inspector general, is unprecedented. I mean, they are looking in every nook and cranny for all these dollars that, they report that can be saved in the Medicaid program. That pressure is not going to go away anytime soon. How you can really interact with us is, how do we get better at what we're doing? How do we become, and to Secretary Stanik's point, more efficient? How do we keep the patient at the center when all of these external pressures are happening and everybody's looking for that million, those millions of dollars that we can save or cut from the Medicaid program? It's a very, very difficult space to be in. And I do want you to hear, we understand, as we're asked to put in more prior authorizations or more things to control fraud, waste, and abuse, believe me, we understand what that means. So also, when we work together, recognize that we get it. We get it. But we have to figure this out together. How do we balance both sides of this most effectively? And we're very open to ideas of how do we balance, to be honest, kind of two opposite poles on our program. So I would just say we've got to think differently. We've got to partner probably at a level we've never partnered before, because if we don't collectively kind of frame this and push this forward, we're going to be at the whims of federal and state legislation that's probably going to force things upon us that are not optimum for the members that we serve or for the work that you do.
And Dr. Brinkman, how can we support the work of, I had lunch with Tanya Dork-Brenner from Overland, Kansas, and I asked, oh gosh, is fluoride next? And I know there's so many different questions when it comes to those things. And she said something that I didn't know, that, there's often a lot of talk from communities about fluoride, but that the only community that actually stopped fluoride was Abilene, but they quickly put it back in. So that's a very positive thing that I think sometimes when we hear all the anti-fluoride arguments, we don't realize how successful that your office and others have been that advocate for oral health. But what are ways we can support your work?
I think the most important thing right now is communication with everyone and to continue our collaboration. We are always looking for ways to support any projects, new initiatives that you guys have. But you need to communicate those with us. And hopefully, if they align with the strategic goals of KDHE and you're as the entity, then we can move forward. But, with our bureau being a smaller bureau, it is really important communication that is open. So that's really what I would call on for all of you, is to, let us know of any projects that you're starting up or any initiatives. And, maybe we can work on those together.
Christina, was interesting because when we look at HR 1, which has such an impact on the state, and we look at the impacts on Medicaid and all the new rules and changes, one of the things I've been saying a lot is, we need to take the resources and try to build the resources we have to keep people on Medicaid, to keep people eligible, with the 30-day look backs and everything else. So with all of you, the question is, as we look at some of the new federal rules and how things are changing and what the focus of the current administration and Congress is, what do you really see as the most important things we should be aware of that impact Kansas, that impact health, Kansas being a place where everyone has what they need to be healthy and a state that's thriving? So how can what's your advice, or how can we support the work of the state of Kansas to ensure that Kansans have what they need as we kind of face some of these federal changes? I don't know, Secretary Stanek, if you want to kind of start us out, or?
Right, I could, gotta hear this thing. There. I thought about this question. Obviously, the impact is to HR 1. I'd like to think there might be some good in there instead of always talking about the bad. There has been though, some safety net program cuts that you're all aware of, and I'm sure that Secretary Howard and Christine could speak about those as well. The provider dollars and the cuts to reimbursement programs like directed state payments or state-directed payments, the provider tax you're aware of, and all of those are going to be diminishing over the next 3 years. And luckily, we got locked in a little bit in Kansas, but it's not sustainable. And so I think that's the word I'd say is where we need help. What can we make in our health ecosystem that's sustainable versus, oh my gosh, they cut WIC or they cut, another program for pregnant mothers or whatever it might be. I think where we could use the help again is strategizing together. And that might mean somebody that's doing a service today gives it up. Perhaps one area gets cut or one type of health delivery organization gets a cut, but could someone else pick it up or could we partner together so that it's not so drastic? I'd say the other thing is the positive is obviously this rural health transformation program, and I don't want to talk too much about that because it's on everyone's mind and we could spend all day, but that really, from a not so positive cuts on Medicaid, this was okay, we'll throw $50 billion into this budget over the next 5 years, and it's going to force states to figure out how to deliver rural health in a different way. I would say that it's replicated, though, whether it's rural or not, because a lot of the things that the state will be working on are strategic. Your organization, along with many other stakeholder groups, will be a part of that. And so you'll be a big help there as well. Thanks.
And I appreciate that, long-term supporters of our work, the CARE Collaborative, we work closely with them, but also Dr. Mosier, comes from Wallace Greeley, one of our long-standing member clinics. Jody Schmidt started the clinic that became First Care Clinic in Hayes. And so they understand, and what I keep saying is that we have to create a system. We have to understand everybody's role, and we have to rethink who does what and how we do it, because there are less resources. And the thing that worries me the most is, we can prop up the system that we have for 5 more years if we were funded, and I don't think that would be funded, but how do we create and how can we be part of supporting some of the change that we want to see, especially when it comes to rural health and across healthcare in Kansas? Is it that we need to partner better? It's really interesting. I've talked to Carrie Bruffett, and she says, well, I want everyone, if we could just get all the healthcare systems in the room and just kind of put the money aside, and we could figure out what the healthcare system should look like. But it does seem like whether it's our work with KDADs and our work with community CCPHCs, whether it's our work, with hospitals, that the money is what seems to always get in the way. So how do we begin to think about the system in a way that everybody thrives? Because we need hospitals, we need CCPHCs. So, as we look at the changes, and I agree, there's some positives there: chronic disease or early intervention. Focus on mental health needs.
Yeah. I think there's an opportunity too when we partner to standardize care, which leads to what Secretary Howard alluded to, and what we're trying to do more publicly in the Medicaid program is show what the outcomes are. We do a lot of work, but it's really hard because we get really busy, and I lived this life in hospitals for a long time. It's really hard to continue to chase the outcomes, but it's what we need to do, or else we're wasting our time planning on the next big thing. I also don't think we should take every opportunity the government says, oh, here you can do this next shiny thing now, because we don't know what we're doing now works sometimes, not all the time. And so I think reflecting on what's important, and I think, you mentioned again, whether it's CCBHCs, whether it's mental health clinic, whatever, we need access to care. And so if we could break down that wall and figure out again, where's the best place? And I think to Carrie's point, or whatever that discussion was about, let's talk about what maybe the top 3 issues are. What are we really trying to solve for, even in this transformation grant? Or because we're trying to solve for everything: staying afloat, quality of care, there's no providers, there's deserts where there's no patient care. There's a whole bunch of stuff, but more of a peel that onion down another layer, maybe, is what I'd say we need your help with.
I don't know if others have sort of feedback on what are the impacts, but also what are the what are the opportunities? It is, we can look at the change and we can talk about the past, but I think we all have to accept, okay, what are our opportunities with this?
So I'll kind of talk on both sides. I'll just a little bit about some of the impacts that are coming. From a overall perspective, if you look at HR1, because we're not an expansion state, obviously our impacts are less than our other Medicaid programs that have expansion. We don't have to do work requirements. We don't have to do the cost sharing. So on the positive side, still means a lot of people are uninsured, but there is in some respects some less burden on Kansas. Where the impacts are coming, and I think this room will feel them probably pretty heavily, is around the immigrant population. In October of 2026, we will have to change our rules around citizenship, which means less people that are here legally will be eligible for Medicaid. We estimate right now it's going to be between 2,000 and 5,000 folks statewide. But already we're receiving a monthly file from CMS that we have to work through to re-verify that people meet the current standards. I will say, we got our first file, 442 members. We went through it, we found one. So I think overall, I'm not overly worried, but some of those impacts are coming. And it is going to move some folks into the uninsured. The other thing I would say from a Kansas perspective, we have to be prepared for, not related to HR1, but just an action that CMS took, is we have continuous eligibility for our parents and caretakers. We've had that since 2012 in Kansas. We have been notified that that must end. We don't have a date yet. And what that means is that that population will not be guaranteed 12 months of Medicaid eligibility once they're determined eligible. We are trying to push that out as far as we can. Obviously, we will wait for direction from CMS. More to come on that. That population right now is about 37,000 in Kansas. Again, not known how many, once we can't guarantee 12 months of coverage, how many will lose eligibility within that 12 months. But obviously, again, I know you deal a lot with, the uninsured population. So that's kind of on the not so great news side. But I do think that what it's going to force us to do is to not think of things in silos. We have this tendency to think, well, this is the Medicaid population, and what should we do for Medicaid? And well, this is the uninsured population. What should we do for the uninsured? This is the commercial population. I think all of this is going to force us to think more holistically and look at them as Kansans. And how do we holistically deal with healthcare in Kansas, and how do we all work together? And there's some states that are really far ahead of Kansas in this. I'm going to point out Arkansas. They do a lot of things that when they look at changes in Medicaid, they look at it both for Medicaid and commercial, which then means it also benefits the uninsured, but they're looking at it more holistically. And then I think the other thing it's going to force us to do, which I think is a good thing, is to be innovative. We're really looking right now at what can we do in the EMS space to allow them to transport to non-emergency rooms. So if they show up, someone's in a behavioral health crisis, is there some type of crisis stabilization or other than an emergency room where they could take that patient that is better aligned and get reimbursed for that? Maybe being able to do some basic stabilization in the home to not have to, transport. We have to get very creative. Just heard a concept that I'm actually really excited about, is allowing what they call self-directed non-emergency transportation. So just like in some of the waivers, allowing family members to transport the Medicaid eligible to a doctor's visit and have some level of reimbursement for that. Really great idea. But I think this is going to be the positive side, is I think we're going to have to get creative, and we're going to have to think outside the box and think broader than just silos. And so I think there's an opportunity in the midst of all the negative to maybe really move us forward together.
And I appreciate that. I think that it's really important that we just think about, like, okay, So we're going to have to rethink some things. And in rethinking some things, what are some ideas that work? I'm so excited to hear about the EMS and that, we have been working on community paramedicine, and some of these other works have had some great sessions on some of this type of work, because I do think it's essential, right? We have resources, whether it's our critical access hospitals or our EMS, they're in our communities. How can we maximize them, whatever that is? Because I think it's crucial that every community have access to an emergency room in an emergency. But how do we use those resources in other ways, or allow those resources to be used in other ways when they're not busy, right? I was just at Wallace Greeley last week. I was just at Cheyenne County Hospital. I was just in Hoxie so some of our member clinics that are also affiliated with local hospitals, and they have to have a doctor staffing the emergency room 24 hours a day. And it seems like some of the efforts to date, like the new change on hospitals and some of those changes, and we think about access to behavioral health that the CCBHCs have, and the 24-hour requirement that there be crisis teams and these types of things. So do you guys have suggestions on, as we think through how to make maybe more with less? Where are those places that you see innovation, or places that you think the system can work better to get more services and care taken care of?
So I'll start. So one of the things that we started prior to the change in administration. This is actually an effort we started in 2024. I think one of the challenges that we've had in Medicaid, and I think it's been to the detriment of the program, is everything is looked at service by service. And so when the legislature starts and the Appropriations Committee, and again, rightfully so, folks will stand up and say, oh, well, Medicaid should cover this service now. Medicaid should do this now. Well, the reality is, if we're adding things a service at a time, we're not going to move the needle. What we're trying to do in Medicaid, and we've started, we did it with maternal and infant health, this was prior to the TMAW grant, is we built a roadmap. If we want to move the needle in maternal and infant health, what is everything that Medicaid should look at, should cover? What are non-Medicaid things? How do we partner better with public health to make the most of resources? How do we partner with the MCOs? But trying to look and think differently. What do we need to do in behavioral health if we really want to move the needle? And it can't be this same old, well, this new service is out. And again, not that those services individually aren't good things, but if we're talking about really improving health outcomes, what is everything we should do in this space? What services should we offer? What new things, does telehealth make sense? Remote monitoring? What are the barriers? Food is medicine. There's just all of these things in the cloud, so to speak. But how do we approach it from that viewpoint of what is everything that Medicaid should do if we really want to move the needle, and then trying to present things holistically to the legislature for funding and get us all aligned that if we did this, array of things, these 5 things, then we really believe we could improve patient outcomes, we could be more efficient, we could hopefully even reduce cost if we're improving health outcomes. So that's really something we're trying to engage in Medicaid is to think differently. And we encourage and we'll be, as we get better at it ourselves, inviting folks to the table to have those conversations. It'll be hard. I'm not going to underestimate it because, if I'm a company and, this is my, there's this new service or a new drug or, whatever that may be, there's always going to be those pressures. But really work with us in trying to think in terms of, as you're working with patients, what are the 5 things that Medicaid should do in this space that if we did all 5, we could really move the program forward?
I think too, there's a lot that we can do in intersecting between the health and what I would call the human services arena. I mean, obviously in the federal changes, we have also safety net changes that impact the SNAP program or work requirements, the citizenship thing paces. I mean, let alone the states having to pick up shares of those costs. But I think, and you all do this because, I mean, as part of your mission, I mean, you recognize whatever language we use about that, you recognize the intersection with income inequality, with housing, with transportation, with all those pieces. That's kind of part of your mission. But one of the things that we've been doing with my DCF hat in the last couple of years is really trying to revamp some of the ways in which we fund and grant dollars. We've kind of had a big silo, say, between the child welfare side of our shop and the economic support side of our shop, where like the TANF program is and the SNAP program are. But the more we start to look at kind of primary prevention, community-based services, the more those lines kind of disappear. So, for example, one of the things we've funded as an agency in recent years has been really investing in family resource centers across the state. And that's really a model that's been very successful in states. Those are really community-driven solutions for what families need. So we have 13 family resource centers embedded in communities. They're doing different things. Some have health connections, and maybe to some of you, some might be more focused on early childhood. But I say all that just because partly what I think in terms of, as we think forward, I mean, it's really important what kind of the overall strategy is. It's also really important what happens at the community level in terms of those intersections and that planning. And one of the initiatives we're going to be rolling out over the next few months that relates to our TANF program, Kansas has a very poor safety net in terms of TANF. The ability to get cash assistance is very much restricted through legislation that passed a few years ago. So out of $100 million in TANF dollars, we only spend about $7 million on actual direct assistance to families. So a lot of the rest goes out in grants. It's gone out in grants for good things, but I would say not a strategic approach. So we're looking to move to an approach this year that we're kind of calling kind of whole family, whole health, and really look at more of a community-based model. I think of it as kind of almost like a United Way kind of a model, where instead of the state kind of giving it directly to, let's give the Boys and Girls Club money, let's give these people money. I mean, more of a strategic approach where more decisions are made at the community level about how those resources might be used. And I say that here today because I think, just the collaboration and the intersection, we all know the impact. We talked about that last night at the Health Foundation event in Wichita. I mean, the impact between income insecurity and health, the impact between upward mobility and health. So again, I think being able to really be strategic with resources across systems and recognizing the intersections with what that means in terms of health outcomes.
And it's interesting you bring that up because I was just going to talk about that side of things, which one of the things we're really beginning to talk about is how we play an economic role in our communities, that it's not just about health, but the other side of that. And the last time I saw you, Secretary Howard, was because I worked with a behavioral health program at KU Med that I never anticipated that our biggest partners would be DCF and justice involved populations. But the system, it's not just the healthcare costs. Unfortunately, it seems like, we can understand saving Medicaid money by keeping people healthy, but we're also keeping kids out of foster care by looking at basic needs, these social drivers of health, all the things. Prevention isn't just health prevention. Prevention, if we're really doing it, prevents a lot of things and allows Kansas to be a more successful place. And so I'm really kind of curious because when we talk about the work of KDHE and all the work of public health, and we are beginning to, worry about vaccines, to be honest, and worrying about fluoride in the water, kind of how can we help make the case for the broad ways that doing some of these things, that we never, yes, do prevent payments from having to happen, because if someone has fluoride in the water and they're a child, they have less likely to have decay, or if they're vaccinated, we know they're less likely to have and spread disease. But how can we start to talk or begin to think through how we can use our limited resources to create a healthy Kansan that's not just based on only looking at savings on the healthcare side of things? Like, how do we help make the case for everything we do that leads to the success of Kansas?
I think a couple of things along those lines. Right when the population health and social determinants movement's getting some traction, we have a federal government and, quite frankly, a legislature in some respects that don't necessarily support those principles. And so it's not us you're trying to convince. I believe that you need to be a loud voice with, and maybe presenting something in a different way to let's just stick with the state, the legislature, profiling your patients in a different way. This number of patients doesn't have a house. This number of patients I couldn't get a ride and canceled visits. I mean, I know you have tons of statistics, but I think if you could make a case and start there to try to, so they understand why these things really are impacting care, I think that would be one thing to continue to emphasize with our state legislature. I'm not blaming them for everything, but as you know, it's been a hard sell for some of this stuff. We'd love to get more into food as medicine, and Christine and Laura and I talk about this. And on another note, I'd say just on the previous topic, I want to just emphasize we are really trying to do a good job executing on CanCare 3.0 because we do have a roadmap. We are really trying to address a lot of the things that are in there. So totally agree, these one-offs cannot continue. If someone presents us an idea, and we even get a lot of internal staff that present ideas, we tell them no or not at this time because if it doesn't fit with the strategy, we're creating our own one-offs at times. So anyways, I'll pass to someone else.
Dr. Brinkman, tell us a little bit about the not only the state of oral health, but how are things going at the federal level? We don't hear as much about oral health, but I know a lot of the work, for example, is funded through the CDC, and there have been a lot of changes there.
Yeah, and a lot of people don't realize, even within the CDC, that the Bureau of Oral Health Department itself has been disbanded. So, we don't even have a representative at that level. Now, we do have 3 contacts, I would say. It takes approximately 3 to 4 weeks before they get back with you when they usually don't have a response. We are in the second year of a 3-year grant that we did that was recently renewed. But, like everything else, federal funding seems to be day to day. It doesn't seem to be real secure. So we're looking at program sustainability. We're looking at more preventative type helps that we can do, I would say. The CDC and at the federal level, they did say that they will no longer support or manage the CDC SILS program or the water fluoridation reporting system. We have decided to take that on at the state level, so we will continue to support our outreach programs that are reporting that data, and we will manage it, and we will now have that data now analyzed. But, on a federal level, we're going back 20 years to where, dentistry is a commodity, and, it's not something that seems to be viewed as a necessity, which is really scary. So, at this point, at the state level, we're looking at ways of preventative dentistry instead of treating what's already existing, educating kids at a young age. This year, we were happy to have introduce oral health education at the Can Be Healthy training, which that will was introduced to all the public nurses throughout the state, and getting some information to them where they can feel comfortable to provide oral health education, apply fluoride, and that such. So if we start at a very early age, hopefully we can make some difference in 15, 20 years, knock knock. So we're losing our support at the federal level, Bills.
So as we kind of finish up with some of the general questions, I'm just really curious, like we've been talking as much as possible from a hope perspective, from a belief that, we can, this has opportunities. So I'm just really curious from each of you, as you think about the next 12 months with, if it's anything like not even the last 12 months, it feels like years, but it hasn't even been a year. Like a year from now, like what are you hopeful for that will make a healthy, successful Kansas? Like where can we go as a state in the next year as we look at these opportunities that you've brought up today? And what are you excited about as we kind of move into the next year? Like what, if you came, when you come back next year, would you be excited to tell us you had achieved?
So I'll start from a Medicaid perspective, and Secretary Stanek alluded to it. I think for us, one big area of success will be CanCare 3.0. And, I think we were very open when we went into this RFP that we really approached it differently. We really not only put a lot of clarity and requirements for the MCOs, but we put a lot of expectations on us as KDHE and KDADs around how we're going to oversee and monitor this contract, how we're going to look at utilization management, how we're going to build dashboards and data sets and really monitor and hold the MCOs accountable, but also on the other side of that, also tout the successes. That is, as easy as that sounds, that's a huge endeavor. And like from a data perspective, we started at zero. And it takes a long time to build data and figure out what the right data is. It sounds easy to say we're going to do utilization management of the MCOs, meaning going in and audit and looking at their processes, looking at files, doing all that. But then it's really hard to say, well, what should we be looking at? What service area, what provider types, whatever that is. So this has been an extremely big undertaking. KDADs and KDHE were working together better than I would say probably has ever happened in the history of the two agencies, but that's not easy to achieve. That's a day-to-day putting structures in place, lots of communication. So while it sounds so easy, it's very complicated, and this endeavor that we've undertaken, we're almost 10 months into these contracts, and I think we've laid a lot of the foundation. There's still a little bit more to lay, and I understand the impatience of the community on the outside looking in, but I think there's been a tremendous amount of work done. So for me, success would be that when we're back here next year, there's a lot of data available that you will have access to, that you can really see, and our members can see. That's a big piece of this, of like our members can really, if they choose to, see how their health plan performs. How are they performing in vaccinations for our young children? In some of these key indicators. So that would be one area where I would say would be, successful for Medicaid. And then on the other side, for those of you, Bethel is coming up in a few weeks. But one of the things that I will be sharing there is our over 45 day application. So, we're held to the standard to process in 45 days. And it will never be zero, but we've typically ran, and we considered a good number to be 1,300, because we get about 12,000 applications a month. So, it's a lot of work. We are now running consistently now in the 700s. Kansas has never been that low, and I would say that's probably one of the best statistics in the nation as far as over 45. Our goal is to get it below 500. So that would be another for us measure of success, because we're trying to straighten the road from application to a decision, because we know that's important for the patient and it's important for you as providers. So if I could come back next year and talk a lot about what we've done in monitoring the MCOs, and then say that, hey, we are consistently below 500 in our aged applications, that would be success. And we survived another year.
I'll touch on in the dental world, what we would like to see is medical dental integration, and for people just not to talk about it, but to actually start moving the needle in establishing a strong collaboration with your medical departments and your dental departments within your health centers. because that can really push the needle on both medical and dental outcomes. And I think as funding decreases everywhere, that we're going to have to see a better collaboration of those departments within your own community health centers. And, you know, we are more than willing. We have done this in, clinics before. We currently have a pilot program going on with a local community health center where we're looking at medical dental integrations and the outcomes with adults living with type 2 diabetes currently. So hopefully next year we'll have some data for you to show you why this is so important. But that would be my ideal wish, dream for next year.
Yeah, and I think that's an incredibly important one. You know, people go to their medical provider much more than they go to their dentist. So it's really important. And co-locating, whether, you know, you can put a dentist and a doctor in and I used to be CEO of an FQHC, and I literally would go out of my office and I could turn to the right and that was the dental clinic. I turned to the left, that was the medical clinic. But getting those two to talk to each other and actually work together, they like each other, but they sometimes don't understand each other, which is a little bit, I think, sometimes like how we are with some of the other healthcare entities. You know, we all have different training and focuses, and then all of a sudden we realize that we like each other, but we're not doing enough together. So,
And in fairness, everybody's busy. And, we have so many questions that are mandated to ask and to answer, and time constraints. We get it, but, we have to remember the overall, why we're there. And the patient is why we're there, and those outcomes and making their life just a little better. So if we could take that extra 5 minutes to ask that dental question, we can really impact people's lives.
and I think we also need to get physicians and other medical clinicians more comfortable with the mouth. That's not any part of the body that they're trained in. And, I've heard physicians say, I don't want to see it. If it's the mouth, that's not me. And how do we make them even more comfortable with those types of things and those relationships? So thanks.
I'll go. I have three things I would mention. One builds a little bit off of what Christine said about CanCare. But in the state, we launched the CCBHC program, and we're the third state to have CCBHC coverage in the nation, to have CCBHC coverage across the state. But sort of launching a program, and folks developing those added services, doing those things, that's kind of only the beginnings. We entered into a federal demonstration project in the last year. Partly one of the reasons I wanted to do that, even though we'd already launched the program, was because I really wanted to make sure that as we continue to sort of morph this system, that we really build in the kind of accountability measures that are really important so we know what the outcomes are. Financially, programmatically, from the consumer perspective. And I've often, as I've talked to the community mental health centers about that, I've often used you all as examples of that in terms of the kind of data that you report to the feds, the kind of dashboards there are, those things, because we never really had that in mental health. And so I'm excited about that because we have a lot of work to do. To really look at, the efficiency of that model, the effectiveness of the model, and then really the outcomes. So a data warehouse has kind of been launched, and so when I would come back in a year, I'd want to have some real data that shows the impact of that, and I would want to see that from a systems perspective, we've been able to make the tweaks and things we need to do to have a sustainable program. I'm also really setting the stage for the potential of expansion outside of the CMHC system in accordance with what the legislature put in place. And I know some of you have interest in that as we look towards 2027. So that's a huge priority to me. Sometimes we launch things and we just sort of let them go. We can't do that if we want it to fulfill its promise and also be, financially responsible, have good consumer outcomes, and meet the impact it's intended to meet. Second area links to this a little bit, is continue to fill some gaps in some areas of expansion. We've invested a lot through CCBHCs and through a number of grants in expanding crisis services across the state, and also in conjunction conjunction with 988, but really building out crisis stabilization services, crisis intervention services across the state for kids and adults. And I would like to be able to come back a year from now and say that we have 24/7 mobile response across the state. We're getting close. We're not quite there yet, but that's again another example where you say, as that comes into play, how does that also fit in there with some of the Medicaid conversations about emergency services and intersecting those pieces together? The third piece, we're building a new psychiatric hospital in Wichita that will have both psychiatric beds and forensic beds. What I want to say about that is, I mean, you can build a new state hospital, but traditionally in Kansas and in many states, right? I mean, our state hospitals, they're not in the middle of a big city. And so patients are away from home. The opportunity for coordinated care isn't there. So I want to be able to say that we have planned for and are ready to open a hospital that is a different model. It's a model where it's in Sedgwick County. The majority of its patients will be from that region. And then we've developed the kinds of coordination and collaboration in terms of care, intersection with patients and family, other providers. We'll also be on a campus that will also have partners in this room on that same campus. And so again, to be able to come back and talk about the model we've created, that's a different idea for how you have a state psychiatric hospital intersected within a community.
Excellent. Got it. There you go.
I'll close out a little bit more high level general because a lot of great examples have been given. But to tie together what we've talked about collectively today, I'd like to come back next year, and you should challenge us to this, and be able to give examples of things today, September 26th, that we knew were on the brink of being cut or had been cut, what we collectively in the healthcare ecosystem did to address that so that no patients or no members of our Medicaid or other program had a gap in care, and how we overcame that. You hear Dr. Brinkman say, CDC quit building the dashboard, we're going to build our own. Things like that. That's back to retooling how we're thinking to address care. And I'd like to think that we can present on those things and say, this is what we did, and we did it together by either you have a program cut or a funding cut, you came to us, you came to the hospitals, whatever, and you figured out a way to fill that void. So I actually am kind of excited. I like the challenge. I'm not a negative person. If it's not HR1, it's going to be something else. And so we all need to just know that. And so I've been working a long time. We all have in healthcare over 40 years. And so this is just the next big thing. And I think there's ways to overcome it. So I'm actually excited to work with all of you and really appreciate the opportunity to see you all. And thank you for the work that you do from all of us.
Riding the waves, right?
Yes.
Riding the waves. That's right. Riding the waves.
Well, getting a little bit into probably the more specific questions, I'm going to start with the one that I know there's not a massive answer to because things are still in process. But just it was great to see the press release go out about the Rural Health Transformation Fund yesterday, to see Community Care Network, not Community Care Network, excuse me, the Care Collaborative, the KU Health System Care Collaborative, kind of helping to lead in how we think about setting up that discussion. But just wondered, what can you tell us about Kansas' approach to that, and kind of what that process is going to look like over the next 6 weeks as we work to figure out what Kansas application will look like?
I'll take this one to start anyways. We have been obviously talking about this and working on what we might do with the governor's office since July, when we knew this was coming. So we haven't communicated because we weren't sure. This was, we're living in uncertain times. So now that finally the notice of funding opportunity dropped, the governor, I just want to start by saying this is the governor's initiative. This is a state-led initiative, and the governor wants to make sure that all of the stakeholders understand it's a state-led initiative. We decided that we did need a third party. The governor did talk to KU. and the collaborative piece. Obviously, Dr. Mosier and Jody have been out and are well respected and have done a great job, have worked with the state on other things. They're already in rural America. They came from rural America. And so we landed on them being a partner to help us put together the application, gather the stakeholder input, and that should start very quickly, like next week. And to gather ideas so that we put together, back to Christine's point, not a one-off approach, not writing checks to organizations to say, yeah, go ahead and do your thing, to be strategic collectively as a state. That's what the focus will be on. There is going to be an alliance that's put together. The governor's signing off on that, hopefully today, the membership. So we have an interstate group, Christine, myself, Secretary Howard, her Chief of Staff, Lee Keck, my Chief of Staff, Matt Laura, Ashley Goss, our Deputy Secretary of Public Health, and Dr. Derek Totten, our Chief Medical Officer for KDHE, are the representatives from the state side that will interface with Jody, Dr. Mosier, and then Marty Ross, who's an attorney that works for a PYA consulting firm, but also does a lot of contract work and has put together a lot of applications and deals for the Rural Health or the Care Collaborative. So our group has been meeting intently over the last week. We will start regular meetings with them. So fast forward, lots of meetings. I would suggest if you're asked to meet, you drop everything because we only have 40 days starting today.
Yeah.
Come to the webinar Monday. That link has been put out. It's at 9 a.m. So you can hear from the collaborative representation. They will explain the process and how the application works, what qualifies, what doesn't. And we want to be very confident. We hope we get both halves of the money. The first half looks like a little bit of a softball because you have to fill an app out and meet certain demographic requirements as a state. We sure are rural. We sure have a lot of rural health facilities, et cetera. The second part is where it gets tricky because we have to put strategies that truly demonstrate they transform healthcare delivery. So all of what we've been saying about rethinking how we deliver, partnering, regionalization, et cetera, all of that's going to be what we'll focus on to get into the application and then hopefully work on getting the money delivered to Kansas so that we can really start strategizing. You guys are welcome to add to that.
I think you did a great job, Janet. I don't think there's too much to add. Great opportunity, 5 years of significant dollars. I think it's really a transformational opportunity during this time where we look for hope and we look for, yeah.
I think we would have all preferred maybe not some of the changes to Medicaid, but this is a real opportunity, and we do have to understand our rural health system and that it is struggling, and it is in many places, and unfortunately some places has already broken, and we've lost hospitals and we've lost access, and so I appreciate that, and I recognize that, I actually appreciate that you're not saying we know everything and we know how it's going to be and here's our application, that we have a very short time, but that we need to have a conversation. One of the things I noted from the notice of funding opportunity was, they're going to pay attention to a robust stakeholder process, and I really appreciate that. Not to go into specifics, but it is interesting. Do you think when it comes to the scoring, because certain things like SNAP, for example, whether you've applied for a waiver on nutritious food or however they want to say it. Oh, we have. I didn't even know. I kind of went through the list and I was like, what?
Our legislature directed us to. We have.
Okay.
It's not been approved yet, but we have an application in.
So it seems like even from the scoring perspective, it seems like Kansas is, in terms of the number of rural counties, things like that, we're pretty well placed. I can't think of, there's so many others that as I was reading through, I was like, yep, we have that one. Yep, that. So do you feel like if we come up with a great plan, we're well placed in terms of all the other requirements and the funding?
I do.
Scores, yeah.
I do, and I think, again, I personally don't think the state could have done this alone without someone that's in the trenches like the collaborative, and with the help of Marty Ross, someone with her background and understanding. The scoring was actually, she kind of had a good handle on that the first meeting we had. So I feel like Kansas is in, we do, as a group, I don't want to say me, I'm not a me person, we do feel very strongly that Kansas will be a front runner for this money, both sides, and that we will put together a good plan. There's already, one of the things that the governor emphasizes is, I'll just say, and she's very engaged, and we're lucky we have a very supportive governor of health care, and not just Medicaid, but healthcare in general. She wants what's good for the communities and so forth. But we have so much good going on in place. How do we put a bow on it and demonstrate that? We also, even with the stakeholder input, we didn't sit and say, oh boy, we better get going. We already have a lot of stakeholder input. Now this will just be additional stakeholder input. And you are right, there is a great emphasis on making sure that the government wants to see that you did go out and you did talk to constituents and you did find out what people really need. And so I think we do that already. And so this is a little easier for us because of all the good things we have going on right now.
The other sort of broad question is the question the legislature is having a lot too, which is, talking about community care coordination. I just wondered, do you have any idea? Can you tell us a little bit about the pilot that's going on with that and where things are potentially going with community care coordination?
You want me to start?
As I know, I promise. None of these are to none of these are to try to trap you into saying anything other than these are important areas of concern or interest.
So this is an area where KDADS and KDHE and the MCOs are working very closely. Community care coordination, the thing, conceptually, it's a wonderful idea. But if I asked each of you, what does community care coordination mean? Probably we'd get 10 different answers. That's the hard part of this. What does this mean for Kansas? What's the best approach for Kansas? And there's been a lot of work being done trying to answer those questions and to get us all aligned, because just like if I asked you, it's the same thing within KDHE and KDADS and the MCOs. If you ask any one of us, we're probably going to answer it a little bit differently. The other kind of side of community care coordination is what, from a federal perspective, they're very concerned about is duplication of services, because we have care coordination in the contract. Well, how does community care coordination not duplicate that? For our waivers that still have targeted case management, how does it not duplicate? And that's, you have to demonstrate that. And again, as the world is right now with CMS, that will be a higher level of demonstration. So, it has to get very, very specific. So all that to say, while again, sounds like a great idea, and it is a great idea, when you kind of peel off that high level layer and you really start getting into what does this really mean, it gets very complicated very quickly. And we don't want to rush, and the program isn't what anybody intended or wanted. That sometimes, speed sometimes is your enemy, sometimes it's your friend. So lots of work going on. I know we're still all looking at 2026, and there may or may not be, a pilot before then. But again, it isn't for lack of not. Things aren't happening, things are happening, but we are being very deliberate, trying to be very strategic. Of course, with the way the world has changed, we're trying to take that into account as all the conversations we just had. What role does community care coordination kind of play in all the other challenges that are happening, which may change what we would have answered this a year ago. If we were sitting in this room a year ago and talking about community care coordination, we might have thought about it differently than we are today because of all the other challenges that we're all facing. And, we all kind of talked about that for probably the first 20, 30 minutes. So again, lots happening. It's still, we're still moving forward. I know it's not the speed people want, but we want it to be the right thing for Kansas.
So this is sort of a Medicaid/oral health question. It's been really wonderful to see the legislature support increasing the dental payments and creating funds so that we can increase payments and get more providers in. And we've done a great job of increasing adult access to dental benefits. And really interested if you're starting to see any data, both from a public health perspective, as well as just in terms of, what kind of data is there on, is this helping? Are kids able to get into dental care better? Are we seeing better outcomes when it comes to adult and their dental health?
I'm going to let Christine kind of take this one. We haven't, we've had a new MCO contract starting in January of this year. And with the dental rates kind of being up and down the last couple of years, I don't know that we've had a full year and that it would be appropriate to kind of put that data out without having that. But I'll let Christine kind of touch on that a little more.
Yeah, and when it comes to data, one of the things that we really understand, I think, in our seats, but I don't think we do a great job of communicating so folks and to maybe right set expectations around data. So when you talk about claims payment is obviously a big source of data that we use. Well, there's always a lag, from when the rate increased in policy. Obviously, it takes a while for, even though you say a rate increase, it takes a while for that to really filter down to the actual provider level. To understand if new providers want to enroll. Once they provide the service, there's a few month lag while that claim works through the process, gets paid, but then that data gets to KDHE because it's submitted to us from the MCOs. So we're always in arrears. And to Dr. Brinkman's point of having the new MCO starting in January. So when you put those lags in, we right now probably have a full data set for Healthy Blue through the end of May. Well, that's 5 months out of a 12-month year. That would really not be smart to start releasing data because people are going to start making assumptions when it's not even half of a year. So I would say we're still probably a few months out from having what I would consider to be reliable data, because the problem is if you put out data, people are going to take that and formulate opinions which may or may not be correct as you get further into having a year's worth of data. So I would still say we're probably going to be early 2026 when we'll have what we consider to be very reliable data.
So I'm going to ask one final question before we open it up, and I hope you guys are getting ready to ask your questions. In visiting our clinics and getting to know our clinics and revisiting many of the clinics I used to know. And I did want to say I especially appreciate, it is true, Governor Kelly believes and knows healthcare. She used to be on the healthcare committee, and I used to appear before her, and believe me, she knows what she's talking about because she certainly held us accountable. But if we're very proud. We just pulled our numbers together, and last year we served 40% of the entire uninsured population of the state. We served 1 out of 4 on Medicaid. So 25% of everyone who is in Medicaid, non-institutionalized Medicaid, is our patient. But we struggle to get the workforce we need. We struggle for oral health, for dentists. We struggle for doctors. And we also have begun to struggle, not even in the places you would anticipate. Communities that, like Topeka, where we can't get the clinical professionals hired. So, as we think about, and so many different ideas have come up, and we've talked about how do we better integrate and coordinate and bring the entire health system together. How can we have just the staff we need? How can we have the locations we need? What are your ideas for how we as a state can just serve more people with Medicaid, who have Medicaid, who don't have Medicaid? How do we create a state where everybody has a locally accessible source of care? And these are not your problems, right? It's not your job to go out and find us the workforce, but how can we kind of deal with some of this? Is the answer multi-state compacts? Is it, are there any ideas for how we can serve more people? Because we always want to serve more people with some of this problems, just the real difficulties we have being able to do so.
I'll start on this a little. I think what we have to recognize is the increased cost of everything. Just the cost of education, that's out there right now, and then getting into public health. I will tell you that, I've practiced over 30, 4 or 5 years. I usually lose count after 10. And, my first 8 to 10 years, I didn't even know public health existed. I think we've come a long way in our dental schools, educating students that the need for public health is out there. More and more graduates are not going to open their private practices anymore. They're looking at different avenues because of the cost of everything. I also think as community health centers, we have to think differently. We have to think of developing programs of maybe growing our own. There are some great dental assistants and great dental hygienists that, if given the opportunity, could become hygienists or become dentists. And, maybe we look at, doing some kind of tuition reimbursement within our own health centers, and then them coming back to serve us afterwards, and promoting our own. I know every one of you in here can think of a dental assistant that you're like, why are you still not, let's promote you. Let's get you, let's get you to, the next level in your career. So we have to think of different avenues to go, because it's costly until we get Medicaid, the reimbursement up to par with the private insurances. And, our coalitions and our advocates have been doing a great job every year getting increases, but we still have a ways to go. And until we get there, I think we have to think of maybe an internal, some kind of a different self-promotion within our own community health centers. I will tell you that, we have a dental school that opened in Joplin, that's feeding in 80 to 90 additional dental students. That's great. UMPC is opening a satellite clinic in St. Joseph, Missouri, that's going to pump in another 10 or 12 students. So, that gives us hope on that front. We're educating more students in the area, and hopefully more and more will stay. But I still think we have to have a greater push on educating the need for public health dentistry.
Well, I think ready for other people if they have questions, if anyone else has a comment.
Workforce is one of the focus areas for rural health transformation. So if folks have ideas, I think it's really going to be important to bring those to the table. So no easy panaceas here, right?
No, they're not. I will point out, where we're waiting on our first question, that we have looked at our numbers, and more than 20% of every single rural Kansan gets care in our clinics as well. So yeah, it is. I think one of the things we haven't done the best job of is telling our story. I don't think anybody. I was in a meeting with Chad Austin from the Hospital Association, and I said 40% of the uninsured, and I saw him write that down. But I don't think people realize that 2 out of 5 people that are uninsured in the state of Kansas come to our clinics, or that 1 out of 4 with Medicaid come to our clinics. We are an incredibly important part. I talk about us as the backbone, and what I mean by that is, like, whatever's not in a community, that's what we do, right? We're not there to get in the way of the rest of the community, but when we talk about healthcare and we talk about why the government intervenes in markets, right? The basic health economics, it's those places where the market doesn't work, right? Where there's not a financial way for people to get what they need health-wise, and that's where we stand, whether it's, focusing on dental health or mental health or medical. It's, we want to exist to fill in those gaps because everyone deserves the health care. So I'm going to allow Dr. Kraft, please.
Thank you for raising your hand. Very much appreciate that. If you have a question, if you could raise your hand, Terry and I will bring the line to you so that everyone in the room can hear your question and have the context for the answer.
Yeah, I'm Dr. Bob Kraft. I'm with Slant Family Healthcare as a CEO. I'm a family medicine doctor by training at Smoky Hill, which is in Salina. That was a workforce initiative established by the state legislature back in the 70s to train doctors for rural Kansas. And so as the leader of that organization, we're trying to expand workforce opportunities. And through some of that work, I have, want to kind of veer into a little bit of opinion here, have become appalled by the workforce opportunities for rural dentistry and the cliff that we're going to fall off of for rural dentists. I do know that there is some effort to look at a Kansas-based dental school And I also have had conversations with other community health centers as opportunities for clinical opportunities for dental students. So I guess I'd be interested in hearing some thoughts around that effort, the efforts to activate Kansas-based dental school, the opportunity for community health centers to be a collaborative partner in having clinical opportunities in public health for those dental students, and just the chance to kind of grow our own. I guess the opinion part is, for me, that would be transformational for the health of Kansans, and a good, discrete thing that we could build with some funds that 10 years down the road would be transformational. So thanks.
So I can't address the dental school in Kansas. I know that's been talked about for years and years, and I don't know why that has not gone anywhere, to be honest. So that I would have to look into more information for you. I think it's important that every one of the CHCs out in Kansas, when I was the chief dental officer at a community health center here in Kansas, we made sure that we had dental students from UMKC do rotations through. Is it easy? No, not always. Does this take up additional time? Yes, but the benefits, we reap them. We always seem to, get a few dentists that showed interest and wanted to continue practicing in the community health center setting. So I think it's real important, if you're not participating with UMKC and with Joplin, to contact them and have students come out on rotations. We did it for the entire year, and it's really beneficial for them and for you, because you can see their struggles and their desires and help them through and see really what we do. And I think we all can change some opinions of what we do in the community for them. Do you practice? Do you have students currently?
Yes. I don't know what happened to the dental school either. That was talked about. I was still in hospitals many years ago. We can look into where that is. I think that the transformational comment, you're absolutely right, and we'll certainly note that as we look to develop the application and so forth. That's not going to be lost. I mean, as far as the delivery, I think when I think of workforce, whether it be dental or whatever, I think I hate to use the term top of license, but it's got to be drilled down on a little bit more. Everybody, we've been on multiple panels this week. There's been a lot of statewide meetings this week in our field, and everybody has the same question, and starting earlier, looking at beyond the typical HRSA reimbursement model, what other things are going to attract people from a work-life balance, and what do people really need to come out to rural communities. I mean, we could go on and on. There are some nice models out there that we're hearing about with some of the universities where they start early and commitment to get into medical school right while you're in high school and things like that. But that's the long term. What do we do to address the short term now? And again, being collaborating together, maybe doing a better job at maybe some more taking care to the patient versus waiting for them to come to us. Nothing that's not been tried, but maybe a more focused effort on that as well would be some of the other things we hear about.
I also think it's really important for us to reach out to your legislators. I mean, we have great coalitions and advocates that do the best that they can. But I think they need to hear from all of us and see the problem that's going to occur shortly. I think the biggest thing with our legislators is that we have to remember that most of them know nothing about oral health. And unless we address it, unless we get that information to them, it's easily to skip over, because there's a lot, what they see is a bigger agenda and bigger problems out there than the dental. And they don't realize the medical dental implications that we can change, to help change if we get the workforce. So I think that's the biggest thing is we all need you to advocate for that.
Do we have any other questions? Wow, I've done a great job. I just have to say, first of all, I'm very, very pleased to see a doctor advocating for oral health. Thank you, Dr. Kraft. We knew you were special, but you're even more special. He's one of my board members, so I have to say.
A unicorn.
No, he's a great guy. So much good has come out of that Salina family residency program. I mean, I think so much. You were talking about the state medical director who is out of that program and also out of Colby. So, we need more like that. I mean, that type of putting students where we want them to practice is how we get students to practice where we want them to practice. So appreciate that. So we have just a couple more minutes. I wanted to kind of let everybody have one final chance to kind of offer any final words, but I wanted to say we are so fortunate. They just talked about they've been traveling the state and got back late last night from all over the place, and the mental health centers are having their meeting this week, Public Health Association, and it is not every state that you have such accessible leaders that are willing to talk and willing to think, and it's also not every state that we have such a high level of experience of Kansas, of experience of healthcare, of understanding the state. So I want to thank you, and I want to thank Governor Kelly for having such an exceedingly wonderful staff that really cares about this state and is doing everything they can, and also really believes and understands why we're part of the healthcare system and essential. So thank you. I wanted to say that before I let you guys kind of say your final words, if anybody has anything or anything that we've missed this morning.
Just to thank for all you do. We can't do it alone, right? So we appreciate it and keep positive.
Same here. Just echo that same comment. It's been great to be able to develop, formalized collaborations with many of you, and we look forward to continuing on that journey. And I am one of those people like Secretary Stanek that I like to think the glass is half full, and there's always opportunities if we kind of keep our eyes open and look for those.
And, I'll just piggyback on everybody, but, more than anything, I want you guys to understand that we truly appreciate you. I grew up in, and it's a situation that, brought me to public health, and I've practiced in probably 25 years within the public health system, trying to serve underserved. I'm still practicing, trying to help kiddos that don't have insurance. I understand it, and I know how hard it is. I've worked in a community health center. I've been an outreach dentist. I've been, at the dental clinic. I've led the dental department. I know the struggles. I know the financial struggles. I know the patient struggles. I know the struggles that you're going through, and I understand them. And we all of us truly appreciate what you do and understand those struggles. And we all are trying to do what's best. It may not always seem like that to you at all times, but just so you know, everyone up on this panel has your best interest at heart, and we're trying to do what's best for the people of Kansas. And, so thank you, basically.
I just want to say thank you. And also, I can't wait to come back next year and hear all the amazing things that have happened in Kansas because of your hard work and our hard work. So thank you so much for being here today.